You are now listening to Nailed It, the Orthopaedic Surgery Podcast.
Dr. Jildeh, welcome back to the Nailed It Ortho Podcast. It's been a while.
Yeah, it's been a minute, man. How you been?
I've been great. We were talking briefly off air, and now I'm into practice. And when we spoke, I think I was still at NYU, or I was doing fellowship, or at least going into it, one of the two. And now I'm in practice, and it's a whole different beast, as you know, compared to beforehand. So, but no, everything's been good. We're trying out different podcast formats. So this one's mostly like video, like we're doing now, and put some clips on there. And so we're testing a couple things out and moving forward. What about yourself?
Well, first of all, I just want to say that's great. The effort you're doing here with the podcast is amazing. I listen to this on my drives to work, and all your time is greatly appreciated. Now, for myself, practice is really good. We're hustling and bustling. Things have been real productive. I really appreciate how my practice has bloomed recently. So very thankful for all the opportunities, both with yourself and with the patients I take care of.
Yeah, and speaking on that, maybe we'll talk about that first. And so what is we always ask just a couple of general questions in the beginning. And so at this point where you're at, because we have people that have actually listened from when I started residency, which was 6 years ago, which is how long the podcast has been going on for, that are now into their practice and trying to figure out how to grow their practice. So what are some things that you notice that help you grow your practice into now, you're hustling and bustling and getting after it?
Yeah, so for my biggest pieces of advice is basically never say no. And I know that's something that was impressed upon all of us as residents and fellows, but particularly as you start, you're going to have some availabilities in your schedule. You're going to have to be asked to see that patient that may be a multiply revised scenario. Always see the patient, always treat everyone like your family member. And I think importantly, when it comes to the operative management of patients, my biggest piece of advice is treat every patient like they're your family member and never leave the operating room until you're 100% happy with the outcome.
I think those are both solid pieces of advice. Definitely solid piece of advice. And yeah, I'm in the process of seeing everything. So like seeing back pain and toe pain and like hallux rigidus and hallux valgus and just whatever comes through the door. I'm like, yeah, of course. Let's put them on a schedule. We'll see it. So I can definitely echo those remarks that you had. And any advice that you would give to if you're looking back on residency, right? Any advice that you would give to a resident as far as preparing for fellowship? I know you have some mentees and people that you mentor that are actually going into fellowship. So any advice that we could give them?
Yeah. So my biggest piece of advice is take notes. Take notes on everything, no matter how insignificant you think it is. Because once you're an attending physician, there's no one to look back at. There's no one to give you that thumbs up that oftentimes you need as a young trainee. And those notes are great to look at too, because you might notice that your residency mentors and your fellowship mentors might do things two different ways, and there might not be a right answer for how certain things are done. So I think my biggest thing here is take notes and pay attention. Enjoy the ride.
Yeah, I can't tell you right now how many times I go back to the notes that I took from fellowship. Like where they put that retractor at again? Like all those things that you don't think are important when you're on your own, it's really important. So definitely echo that. And in today, so we're gonna talk some sportsy topics today. So we're gonna talk some PCL injuries, so we can kind of transition into that. So for those that are listening, that have listened to our episodes about the ACL, and they know all about that, they know all about MDI, but now we're talking about the PCL. Can you kind of just go over just some relevant anatomy that people should know about the PCL, the different bundles, etc.?
Yeah, so very common thing is to compare the ACL to the PCL in your mind, but there's a couple notable differences I really want to hit on. So one big difference is that the PCL is an intrasynovial and extra-articular structure with synovium covering the entire ligament except that posterior part. Contrast that to the ACL, which is an intra-articular and extrasynovial structure. So there's some notable differences there, and we'll probably touch upon those later in terms of the management of PCL injuries. Now, regarding the anatomy, the PCL originates at the lateral aspect of the medial-femoral condyle, adjacent to the articular cartilage, and it inserts down the PCL facet of the posterior tibia about a centimeter and a half below the articular surface of the posterior tibial plateau. It's pretty much just down that champagne glass drop-off of the posterior tibia.
Yeah, and in your experience, what has been like the typical mechanism when somebody comes in and they have a PCL injury? Like, wow, how does it occur? Like, who are you seeing these in?
So really, you see this in two different groups of people. So firstly, people through a high energy dashboard injury, usually a direct blow through the anterior tibia, and that's usually like if someone's riding a car and they have a dashboard hit their anterior tibia and it puts a large posterior force onto that tibia. In athletics, usually it's oftentimes patients that fall on a plantar flexed foot. And I want to bring up one thing. So, if patients fall, there's two differences, right? So if the foot's dorsiflex, that force is transmitted through the patella and extensor mechanism, and oftentimes that leads to injuries in those structures. However, if your foot's plantar flex, there's a posterior directed force through the proximal tibia, and generally that's where PCL injuries come from. And patients with PCL injuries often present a little bit different. They might notice some mild to moderate swelling. They may not report that pop as they do with ACL injuries, and they may not even report a sense of instability as many patients do with ACL injuries. So you definitely have to have an index of suspicion from the history and physical.
Yeah, and can you kind of just briefly touch base on the different bundles? Because I know when we talk about ACL, we talk about they have a couple bundles that function in different states and in different degrees of flexion. But what about the PCL?
So there's two bundles. There's a larger anterior lateral bundle and a smaller posterior medial bundle. Again, when you compare it to ACL, ACL has an anterior medial and posterior lateral. For PCLs, they have an anterior lateral bundle and a posterior medial bundle. And the difference is that the anterior lateral bundle is tight in deep flexion and is the main resistor to tibial translation at those deep flexion angles. And the posterior medial bundle is tight in extension and is the main resistance to tibial translation at knee extension angles.
Yeah, I was thinking about it. If you think about it, even both the anterior something bundles of the ACL and the PCL are both like tight during flexion, and the posterior bundles are during extension. That's one thing I realized. Oh yeah, that makes sense. Just a little bit. The bundles are a little bit switched around when you talk about the ACL and the PCL. But yeah, exactly just what you just said. And so, say you have somebody that comes in concerned about a PCL injury. Well, I will say the ones that I've seen, I haven't just seen an isolated PCL injury yet, but the ones that you're concerned when you're seeing them in the clinic, what's your history exam like? Like, what are you asking them? And then what is your physical exam like? Like, what are you checking out? Like, if we're all in your head and there's a patient that you're looking at now, like what is running through your head?
So history is really important with these patients. You want to really understand the mechanism. You want to understand the energy that's imparted through the knee. You want to be very thorough with understanding exactly the chronicity of the injury, because that contributes, as well as the patient complaints. And as we stated, there are some notable differences between patients who present with ACL injuries and patients who present with PCL injuries. And also notably, I should state that PCL injuries oftentimes have they occur in combination with other ligamentous injuries as well. So due to this, it's really critical to examine the contralateral knee first prior to comparing it to the injured knee to really get a sense of what the patient's native God-given anatomy is. So regarding a physical exam, there's several tests that I do. I make sure I'm very thorough with these patients. So firstly, I start with the posterior drawer test. So I think it's important to note that on an uninjured knee, the medial tibial plateau lies approximately 1 centimeter anterior to the medial femoral condyle. And all posterior tests have to start this resting position. Otherwise, there's a high chance for a false positive. So for a posterior drawer test, simply you have a patient supine, their hips at 45 degrees, the knees at 90. The examiner or yourself presumably places your thumbs on the anterior joint line and you put a posterior directed force on the knee. And the exam is simply graded based on the position of the tibial plateau relative to the medial femoral condyle, with a grade 3 exam demonstrating about a centimeter or 10 millimeter translation posterior to that native position. Next, oftentimes I move on to a posterior sag test where I place a patient in a supine position and I hold the patient's lower extremity with the hip and knee both at 90 degrees. And I look for a posterior sag of the tibia or a loss of that prominence of the tibial tubercle, indicating a positive exam. The quadriceps active test is also really important, and this is a good way to test the PCL without applying a passive or active force. Here we have a patient lie supine with the hip flexed to 45 degrees and the knee to 90 degrees, and you ask the patient to activate the quads while holding their foot in place. And a positive test occurs when a contraction of the quads shifts the tibia anteriorly from a posterior sublux position, thus reducing the knee. And lastly, one other test that I want to mention, of course, I'm sure you guys touch upon this in your posterior lateral corner podcast, is the dial test. And I think it's really important to do this on all PCL injured patients due to the high rate of concomitant injuries. And just to briefly review, this is when a patient's lying prone. You would examine the patient's feet and apply an external rotation stress on both their lower extremities. And you look at the angle between the medial border of the foot and the axis of the femur, both 30 and 90 degrees, with the difference more than 15 degrees demonstrating a positive result. And of course, a positive test at 30 and 90 degrees indicates a combined PCL and posterior lateral injury, whereas a positive test at 30 degrees demonstrates just an isolated posterior lateral.
Perfect. Yeah, no, that's great. So just to recap, you mentioned doing the posterior drawer test where you have their hip at 45 and you have their knee at 90. And really you have both your thumbs on the plateau and you're measuring in relation to the condyles, if it goes to the condyles or posterior to the condyles. And you mentioned those grades, with grade 3 being more than a centimeter posterior to the condyles. You mentioned the posterior sag test where you had the hip flex and the knee flex, and you're looking at that tibial tubercle to see if you have that loss of kind of that contour. You talk about the quadriceps active test where you have their hip flexed at about 45 and you have them contract their quadriceps and it basically subluxes the tibia shifts anteriorly, right, from a posteriorly subluxed position as well. And you also discussed doing the dial test. So you have them prone on their belly and you check their external rotation in comparison to their contralateral limb with their knee flexed at 30 degrees and then with their knee flexed at 90 degrees. If it's increased in both, you may have a combined posterior lateral corner injury plus a PCL injury. But if it is just increased at 90, you may have a just an isolated PCL injury. That's correct?
Correct.
Yep. And so what imaging are you getting? Are you getting x-rays? Are you going to MRI? Like what, are you getting CT scans? What goes through your head? Are you getting long length alignment films on everybody? What do you do?
So this is really something we can really nerd out on between you and I.
Let's do it.
So obviously with all these patients, you want to start with an initial evaluation, a knee series essentially. So all my patients start with an AP lateral sunrise, 45-degree knee flexion, weight-bearing views. And then in addition, I do obtain leg length x-rays on all my patients, and the purpose of which is to evaluate coronal and sagittal axis deviations. And I think particularly this is more important in a chronic scenario because patients can develop these abnormalities with chronic knee injuries. And these radiographs are really important to, assess really the state of the knee and really to make sure there's no avulsion injuries. If there's a suspicion for a PCL injury, particularly from my history, I have these patients get stress x-rays or kneeling x-rays, which I'm sure you have familiarity with from your fellowship and your practice. And the purpose of these is to quantify the magnitude of posterior tibial displacement on these injured versus uninjured knees. And the way these are measured is you have a patient kneel and you measure from the posterior cortex of the tibia to Blumenstadt's line. And 0 to 7 millimeters side-to-side difference in posterior displacement denotes a partial PCL tear. And 8 to 11 millimeter constitutes an isolated complete PCL tear. And over 12 millimeters of posterior translations demonstrates probably a combined injury of the PCL and the posterior lateral corner. And these numbers are validated by Laprod's group. And then, of course, if there's a posterior lateral corner injury, I obtain various stress x-rays and I assess the side-to-side gapping where the numbers I'm looking for are 2.7 millimeters, 4.0 millimeters, and 7.8 millimeters of gapping, which may denote isolated LCL injury, grade 3 posterior lateral corner injury, or a combined posterior lateral corner ACL or PCL injury, respectively.
Now, are you going back and stressing them yourselves, or are your radiology techs trained and know how to do these stress x-rays?
For these patients, I have my radiology techs take care of the kneeling x-rays because those are pretty self-explanatory. Unless it's an acute injury, the patients might be guarding a little bit. Now, for the varus stress x-rays, I think it's really important that we as orthopedic surgeons do that, particularly since we don't want to cause any rotation in the knee when doing these. And it helps us give us a guide and a sense of what's going on in that knee. And one thing I forgot to mention is these patients, if I do have a suspicion that they have a PCL injury, I do go ahead and get an MRI. But the one thing I want to note for an MRI is that it's the highest sensitivity and specificity exam for acute PCL tear. However, in chronic PCL tears, the signal and shape of the PCL can be deceptively restored during the healing process, and there still may be residual laxity. So I just want to give you that word of warning with MRI in these patients.
Yeah, and I mean, I think that's a good note, especially to know about the chronic PCL injuries, right? And those are definitely good to mention the stress radiographs that you get, right? The kneeling radiographs, the varus stress radiographs, measuring the gapping, on the outside part of the knee. And so say, for example, really quick, how often are you seeing isolated PCL injuries or are you seeing combined injuries?
More often than not in my practice, they're usually combined. It's kind of rare just to get an isolated PCL injury. And I'm sure that's the same with yours as well.
Yeah, I've only seen I think I've only seen one isolated PCL, and it was in South America. I was working in Bogota, Colombia for about a month, and I did like a sports rotation out there. And I remember seeing the only isolated PCL that I've seen so far. But most of these, just like you said, I've seen in conjunction with other ligamentous injuries. So that being said, how's your treatment? What's your treatment algorithm like, right? At least my class, we're all going into board collections very shortly. And so we need to have a strict, guideline of how we do things. So what is your treatment algorithm, and how do you explain to the patient their different treatment options?
So, prior to treating any of these patients, it's really important to grade the injury. And it's graded from grade 1, grade 2, and grade 3. And simply that's denotes how much laxity these patients have on stress exams. So with acute grade 1 and 2 tears, which denotes most of the injuries that we're going to see in our practices, these are generally partial tears, and they do great with physical therapy, focusing on quad strengthening. Usually you want to tell these patients that they shouldn't play any sports for 6 weeks, and there's a huge role for dynamic bracing. And what that does is it stabilizes the tibia, and it pushes the tibia forward with increasing degrees of flexion of the knee. Surgery for these acute grade 1 and 2 tears is really only reserved for chronically symptomatic patients who failed non-operative treatment or combined injuries, since PCL injuries can increase graft forces and loads. So let's say it's a posterior lateral corner and a PCL injury. That patient meets the indication for operative intervention. I think it's important to touch upon grade 3 injuries where you have quite a bit of laxity, as we spoke about recently. Those patients generally do meet indications for operative intervention. So grade 3 injuries are those who have quite a bit of posterior translation with that posterior drawer. And oftentimes these are frequently associated with other ligamentous injuries anyways, like the posterior lateral corner. But it's really important to address those because after some time, there's some research that substantiates that these patients can go on to medial-femoral condyle as well as patellofemoral arthritis, and the rates are up to 80% after 5 years.
Yeah, I actually think that might have been a test question, or I know I've definitely seen questions on that as far as PCL insufficient needs, or maybe I got pimped on it as a resident. One of the two, one of the three, but
Yeah.
definitely something that people definitely need to know about. PCL deficient knees or pattern of arthritis, right? Or just like the same thing in an ACL deficient knee, that you may have more, medial meniscus tears as a secondary stabilizer. Kind of just knowing overall the function of the knee and how it works. So the dynamic brace, how long do you have them? Because I realize in residency and in fellowship, you worry about mostly, not worry about it, but you're mostly operating and you're not doing as much as the clinic non-operative side of things. So how long do you have them in this brace for? Is it those 6 weeks, or do they start off in this brace, in this dynamic brace that you mentioned that translates the tibia anteriorly?
So it really depends on the grade of injury. If it's a higher grade injury, like a grade 2, usually I have them in for that 6 weeks. But if it's a grade 3, or if it's someone that I operate on, it can be for longer than that. I'm pretty slow with returning those patients back. I want to make sure that that PCL heals appropriately and that we can take care of any residual laxity that may result.
And how long do you tell them that? I know you mentioned that you told them they're not playing sports for 6 weeks, but say, you got a football player, he wants to know like when he's going to be able to go back, practice full speed. Around what time do you tell them? What time?
Usually, just to be safe, I say between 8 to 12 weeks, but really what I'm looking for is full range of motion, no pain, and a resolution of strength or equal strength from side to side. So oftentimes with our higher level football players, some of which I take care of, they can beat that time frame. But I think usually I give them a little bit more of a conservative estimate.
Okay. And so say now we've gone into we have our patient now, we're going to non-operate the grade 1s, some of the grade 2s would say we have a grade 3 or a patient that has a multiligamentous knee injury, ACL, PCL combo. What are some of the different operative techniques, right? Because we talk about the ACL, there's single bundle, there's maybe different bundles. Like what about the PCL? What are some different operative techniques and things we should know about it?
Yeah, there's a lot of work being done on PCL injuries. So you kind of touched upon this. So there's a single bundle and there's a double bundle technique where the single bundle really aims to recreate that anterior lateral bundle. And of course, the double bundle aims to recreate both the anterior lateral bundle as well as the posterior medial bundle. And then, of course, there's different techniques for fixing the PCL as well. There is a transtibial technique as well as a tibial inlay technique. And the purpose of the tibial inlay technique is essentially to avoid that killer turn that's thought to cause graft laxity or graft damage that you may get with the transtibial technique.
Can you describe what the inlay technique is for, say, the fourth year resident that's doing their sports and they kind of have an interest but don't really know too much, but they can figure out the transtibials that you drill all the way through the tibia. So what is exactly the inlay technique?
So essentially what the inlay does is you use a posterior medial incision, although there are some newer arthroscopic techniques to describe this. The approach is between the medial head of the gastrocnemius and the semimembranosus. Basically what you do is you inlay a bone block on the posterior portion of the tibia, again, to avoid that killer turn going into that tibia causing graft failure.
Yeah, and then transtibia is you drill completely through the entire tibia, and it makes that turn. And so, what is maybe this is a little sportsy, nerding out a little bit, but so what's your technique of choice, and then what's your graft of choice for PCL reconstructions? You could say it in a multiligamentous knee case.
Okay, great question. So I'm going to go into a little detail here because I think there's some salient points I think the listeners should be aware of. So usually for a lower level type person, I do a single bundle technique where I use an Achilles allograft with an intact bone block. And then for a higher level person or athlete that wants to return back to higher level high school or collegiate sports, I go forward with a double bundle technique where I use a split Achilles for the anterior lateral bundle and a tibialis anterior graft for the posterior medial bundle. And I think it's really important to establish a posterior medial portal. And I just want to talk a little bit about this. The purpose of this posterior medial portal is to accommodate debridement in the back of the knee, particularly down that champagne glass. And if you may recall, you have to go pretty far distal down, really up to 1.5 centimeters down. And it's helpful to have a 70-degree scope through the Gilchrist portal to accommodate all this. And it's really helpful to use x-rays as well to identify the location that you're drilling, of course, because there's some really dangerous things back there. But you also want to put the tunnel in the correct position. Regarding the femoral tunnel, when I do a single bundle, usually I drill in an outside-in technique. However, when I do a double bundle, I drill in an inside-out technique where I use a reamer to locate exactly where I'm going to put both bundles. So if you're pursuing a double bundle, you of course want to recreate both bundles. And I use the reamer as a guide right up to the articular surface with about a 2 to 3 millimeter bone bridge to recreate the posterior medial bundle as well. And I bring both those bundles down a single tunnel in the tibia. Before passing my graft, of course, I do use a Gore-Tex chamfer. I'm sure you've seen that in your practice. And that's just another effort I make to minimize that killer turn for the PCL as well. And then, of course, when it comes to tensioning operatively, I think there is an art to tensioning these grafts. So if you just do a single bundle, you want to fix the tibial side at 90 degrees of knee flexion with the knee in slightly an anterior drawer. However, if you do a double bundle, the bundles must be fixed independently. So I like to fix the anterior lateral bundle 90 degrees, and then I proceed to extension and neutral rotation to fix that posterior medial.
Yeah, no, I think those are all great points, right? Especially the Gore-Tex reamer to help with the killer turn. And I've also noticed that can help with pulling the graft up. Like if you're trying to shuttle the graft through. I remember we were in some cases where there was some difficulty with that, and the Gore-Tex reamer helped out. And then just like you just said, the position that you fix it in, right? So if you're doing a single bundle, you'll fix the knee at 90 degrees with whatever your fixation choice, but with a little anterior drawer, right? And then if you're doing the double bundle, you'll fix the anterior bundle with the knee at 90 degrees and the posterior bundle in extension with neutral rotation. So those are all salient and great points to make. Do you use a bone block in the femur when you're using an Achilles for your single bundle with a screw
Absolutely.
to hold it?
Yep, I use a bone block in the femur with a screw, and then oftentimes I these days have switched to a screw on the tibia as well.
Yeah, I do the same thing. Or I will do that. I will. I haven't gotten a PCL yet in practice, but I'm sure one will come. I just did an ACL a couple of days ago, so I'm sure the PCLs will come. And so I do pretty much the same points that you just made. Definitely use of the 70-degree scope and use of the posterior medial portal I found to be pretty helpful with PCL injuries. And then rehab. What do you talk to them and let them know how rehab is going to be like afterwards? Say you fixed it, right? And so what they're asking, like, when can I come back to play? This is if I did non-operative, but if I get it fixed, like, when am I going back to play? When am I going to practice? What do you tell them?
So one thing I'd like to know is that usually these patients have about an 87, 90, 95% return to sport after operative intervention. So the return to sport is pretty high. Oftentimes these patients do have some residual laxity, and you may feel this both in your practice and PCLs done by others. So it's really hard to take out all laxity, but That's why that double bundle was developed. It was developed to take out, it was an attempt to take out all residual laxing. And there are quite a few levels 2 studies to substantiate that. Now, for rehab, I think we should touch upon some principles. I think that the return to sport after a PCL reconstruction kind of echoes that of an ACL reconstruction. You want to go slow, particularly in the beginning. And the principles that should be followed in the beginning are that you want to minimize that posterior sag. You want to mobilize that patella and help reduce scar tissue. My patients are non-weight bearing for 6 weeks after their PCL reconstructions. You want to initiate early quad activation, and then you also want to initiate early prone knee flexion in the beginning. And again, that's because these patients do have a high propensity to get stiff. I do like my patients to go into a dynamic knee brace. Again, the purpose of that is to keep that knee reduced while that PCL heals, while translating that tibia forward. And of course, rehab goes in multiple phases. And I like to think in paradigms of ACL, and I think the paradigms for PCL reconstruction are very similar, with the notable exception that you really kind of want to go slower in the beginning.
Yeah, perfect. So I think it was a great talk, great overview. I think we touched on a good amount of the points with PCL. We talked about the different bundles, how to examine them, the different maneuvers, how to image them, what you're looking for in imaging. We talked about non-operative treatment, the treatment timeline. We talked about operative treatment. We even touched on some of the techniques on tibial inlay versus transtibial. I don't know if I've actually done a tibial inlay. I think all the ones I've done or seen have been transtibial. Now that I think about it, have you done an inlay?
I haven't. I do transtibial primarily as my technique.
Yeah.
And like I said, in my practice, usually it's a double bundle reconstruction. Tibial inlay is kind of a tricky thing. And I think it was to address the purpose of which is to address that killer turn. But I haven't really seen any powerful research to substantiate really the benefit of one over the other.
Yeah. Yeah. Well, anything else you want the people to know about PCL injuries before we wrap up here?
Not particularly. I think there's a lot to be learned about PCL injuries. I think that we as a community are awaiting more high-level research on the subject. And, my ear is very close to the ground regarding this injury. And you do see them, and you're going to see them more and more, particularly as football season, next fall approaches, I should say. But I think that we're doing a pretty good job, but there is room to improve.
Well, perfect. Well, thank you again so much for coming on the podcast. It's been a pleasure talking to you again. It's been fun. I'm sure we'll do this again in the future. Maybe another year from now, we'll think of another sports topic to talk about. But again, thanks so much for coming on.
It's my honor. Thank you so much. Looking forward to doing it again.